read-only mode.
I'd like to welcome everybody here today. I'm Christy Beck-Nelson. I'm the Regional Director of Oncology for Providence, and we are very grateful to have Dr. Liu here today. It's my pleasure to introduce him. He has a background in biochemistry. He attended Columbia University, where he did general surgery residency. He's done research fellowships in islet transplantation. He has studied in Sweden. He has also attended Vanderbilt University and has a Master of Science in Clinical Investigation. He is the Chief Medical Advisor and founder of the Healing Net, which is an organization dedicated to the study and awareness of neuroendocrine tumors. And we really appreciate him coming west to Missoula today to share his work with us. So thank you for being here, and we look forward to hearing what you're going to teach us about today.
Great, thanks, Christy. I appreciate it. There we go. Is that better? Yeah, great. Well, thanks for having me. Thanks, Christy, for the introduction. I'm really excited to be here. I've never been to Montana before. I kept hoping I would see a bear. I haven't seen a bear. But I did see a frozen lake, which is pretty good. And I saw a tree get blown down with C4, and that was pretty exciting. So only in Montana can you see that. But it's a real pleasure to be here. I appreciate the invitation. And you might be wondering why did I come all the way from Tennessee to the corner of Montana to talk about this strange, unusual tumor. Well, the reason I do this is because this is a strange, unusual tumor, but it's actually a more common problem than you think. And there are people all around, everywhere. I mean, I have patients who fly from Montana down to Nashville to see me. And so I feel like the more I can get out there and educate people, the more people can feel just a little bit more comfortable, or at least a little bit of awareness of this disease, so that the patient doesn't feel so lost, because it is very frequent that the patient has to take their care into their own hands, and they will seek out help from all around the country. And I just want to make sure that everyone has a sense of what's happening, so that you understand what's going on, why their treatments are so different from kind of the usual chemotherapies we give. And for you to just understand that this entity exists, which is probably the most important thing. So I'm going to tell you about neuroendocrine tumors. This is what I call a growing and unusual problem. And growing is really just because it's a cancer. And the way I'm going to structure it is we'll talk a little bit of an overview about what neuroendocrine is, because I'm sure most of you don't even understand what that word is. We'll talk about how you work it up. We'll talk about PATH, which is kind of the standard. Any pathologists in the room? Oh, good, so I won't look at. We'll talk about the multiple therapies. Despite the fact it's an unusual cancer, we actually have a bunch of tools in the toolbox, which I'm very, very blessed and thankful for. We'll talk about some technical things too. We'll talk about the AJCC staging system, and we'll talk about the NCCN guidelines. If you have any questions, please feel free to interrupt. And I'm sure if you have a question, the whole group has a question too. So part of it, though, is just my ranting and raving up here. So if you can tolerate that, I hope you'll learn something. So let's start with what neuroendocrine tumors are in general. So you would be surprised at how complicated it is to eat and breathe, right? So we're 3,000 feet above sea level here. So processing that oxygen is a little bit more complicated. And I always say we should be very thankful that God and Mother Nature, when you were constructed, didn't make you think about breathing and eating, because you would do a terrible, terrible job, I guarantee you. But there are tiny little cells scattered throughout your lungs and your digestive tract, which helps to regulate those things. The regulation of airway passage, the regulation of food passage, the absorption. And those tiny little cells are called neuroendocrine cells. And the way they function is by secreting hormones. And these are hormones we know about: insulin, gastrin, glucagon, kind of the usual things we hear about. But in fact, one of the major hormones is serotonin. And when we think of serotonin in general, we think of, oh, well, Prozac and SSRIs and things like that. And you think, well, obviously the number one producer of serotonin in your body must be your brain, right? And that would be a trick question. Obviously, I was tricking you. The number one producer of serotonin is your gut. It's a very powerful gut hormone, and it helps to regulate kind of gut function. And so next time you have a gut feeling, that's a very powerful biochemical process, so you really should trust it. But you can see there's a lot of hormones involved. And this is, I mean, this can't be but, what, 1% of the true hormones that are available in your body, conservatively guess. And the interesting thing is that all of them express something called the somatostatin receptor. So I always say somatostatin is a very powerful hormone, and I'm glad we have it, because somato means stop. I mean, it means body. Statin means stop, so it stops your bodily function. And I tell people, I said, well, you know, God created that because if you were being chased by a tiger, it would be a bad time to have diarrhea, right? So there's that braking system, so somatostatin receptor. And we are very thankful because we've exploited it to the max, and I'll show you how. Now, we've been troubled a little bit by the terminology for the past 100 years, unfortunately. Just a little bit of history. In 1907, Siegfried Ockendorfer, the man pictured here, first termed the word carcinoid. And the way this happened was he got a case. He's a pathologist, looked under the microscope, and he saw, this looks like cancer to me, but it's not quite the cancer I'm used to, which is adenocarcinoma. So he called it carcinoid, carcinoma-like. About 7 years later, he collected several more cases, and he watched these people apparently die terrible deaths, really metastatic, awful deaths. And he realized he made a mistake. This is a very aggressive, strange cancer, but it's certainly a cancer. But that term has stuck for 100 years. So the term carcinoid, unfortunately, people think, oh, that's not really cancer, right? It's still cancer-like. And we still call it a benign carcinoid, but in fact, it's a highly, highly metastatic disease. So it's an issue because if you're a carcinoid patient, and if anyone, I know there are a couple of patients in the room, they had the experience of going, say, to an ER or someone who's or a quick clinic and they're not familiar with it. They say, well, I have carcinoid. People will say, well, that's not cancer, right? And they'll say, well, actually, I have bone and liver mets. So it's just to give you a sense of this, how the terminology affects it. And it's been a problem. They were called apodomas for a while, sometimes called islet cell tumors, and finally we came with the term neuroendocrine. Neuro because of the pathologic staining, the synaptophysin, and the features that are similar to neurons, and obviously endocrine for hormones. So this is really the term we've come up with. And it's more of an umbrella term, think of it that way. It's only been around for about 15 years now, since about 2000. So luckily we have it. But if you want to think of still that old term of carcinoid, the carcinoid would be something that comes from a tube, so either a breathing tube or a digestive tube. But really we're trying to get away from that. So we're trying to call them bronchial carcinoid tumors, bronchial neuroendocrine tumors, or small intestinal neuroendocrine tumors, just to kind of keep things a little bit more uniform and to also get rid of that stigma of the word carcinoid. But it's still very popular, so I don't begrudge people when they use it. Now you'll say, well, Eric, how can you possibly make a living off of this tiny little tumor set, right? Because my wife asks me that every day. But it turns out neuroendocrine is really just a generic term. There are 15 different types of tumors right here, you can see. And where they come from very much dictate how they behave. But more importantly, each one of those has 3 subtypes off of that, and each of those subtypes has like 5 different varieties off of that. So when it comes to really taking care of neuroendocrine, it's very, very personalized because the one who walks in the door is different from the one that just left the door. So that's why I always encourage people to see specialists, because if you use the cookie-cutter kind of approach to neuroendocrine, it won't be ideal. It's not wrong, but it certainly won't be ideal. So you can see how these can be very, very complicated once you start to sort these things out. And it's a problem that's growing that we've seen. Certainly I specialize in it, so it's not fair to come to my clinic. You'll see 15 neuroendocrine patients in a row in my clinic. But as I kind of go around on, preaching the gospel and spreading the word, a lot of docs will tell me, gosh, I've seen more this year, there's more happening, I don't really know why. And I don't know why either, but certainly the incidence is going up here and around the world. And if you look at it, certainly in 1983, this was a rare cancer, no question. But it's been going up steadily over this time. And a lot of this has to do with better surveillance, better ICD-9 coding. Certainly that's important. But the rate continues to kind of creep up. And if it does, it's going to be a growing problem over the next generation, essentially. So I'm glad I can be here to help take care of it. And you can see here, it must be something to it, because even the different types of neuroendocrine tumors themselves have different increases of incidence. And you can see here, most of our kind of pancreas and stomach, they're relatively stable, appendices. But the ones that are really shooting up are lung, are going way, way up. And as far as I know, chest x-ray hasn't changed a whole lot in the past 30 years. Small intestine has gone way up, and we still don't have great ways of surveying the small intestine. Rectum has gone up, and that's probably because of colonoscopy. I'm very delighted by that. But you can see how even within our neuroendocrine breakdown, there's quite a difference in incidence. And this is about 25% of all neuroendocrine cases from bronchial, and digestive is about 75%. Now, incidence is one thing, right? So those are the new cases that show up in the United States. You would be shocked how many people are walking around with neuroendocrine. This is the prevalence in the United States. Hepatobiliary, esophageal, pancreatic. We know that this prevalence is relatively low because we are delighted when they can live 3 years, right? These are very deadly cancers, gastric as well. But look, there are actually over 100,000 people in the United States walking around with neuroendocrine. So caring for them, because it tends to be a slow-growing tumor, because we can diagnose it a little bit better now, there are a lot of people walking around. So there are a large population of people who need care. Now, unfortunately, when they walk in the door, they tend to be complicated, and this is part of the disease history, natural history and process. Again, look at rectum. You can see, since we're doing so many colonoscopies, most of them show up as small primary sites, and that is great. I'm very happy about that. Mostly because then we're going to pick up the adenocarcinoma that's somewhere else in the colon. But look at our bronchioles, okay? So our lung carcinoids, our bronchial neuroendocrine tumors, only half of those are primary, half of them already show metastatic. Look at the small bowel, it's even worse. Over two-thirds show up metastatic. So they have already advanced the disease when they show up to your clinic and eventually to my clinic. And this is because the delay of diagnosis is often 5 to 7 years since the onset of symptoms. So you can just imagine what it is like for a patient to have gone to a doctor, a primary care doctor, and prescribed their PPIs or their H2 blockers. They have their colonoscopy, they've had their endoscopy, they don't find anything. This lingers and lingers and lingers until finally they randomly get a CT scan and they find liver mets. It's a very common story. It's a terrifying but common story. And it's especially common, especially with small bowel, since we still don't have great ways of surveying it. So this is just something to think about. And really the story here, especially for the patients, so I gave a talk last night for the community. And the story really is, if you have persistent symptoms and something's not going right and the usual maneuvers don't help, don't be shy about pursuing it. And really, and I'm not here to cause a panic or anything, because this is not a very common disease. But still, you just want to know your differential diagnosis, because if you don't think about it, you never work it up. You don't send the right markers, you don't do the right CT scans and things like that, and you'll miss it. And it's just a very common story. So this is hopefully a very sobering kind of graph for us to think about as physicians. And you can see the survival with metastatic, it's a small bowel carcinoid, is still okay, right? So this is actually over many years. This is 5 years and 10 years. So we can still get people out quite a long time compared to our normal adenocarcinomas. But it would be great if we could get the curve all the way up here, right? And that's what the Europeans have done. So in general, when you work with a patient, the reason part of it's so complicated is because the symptoms are very soft. But there are some pearls, some tricks I want to tell you about. So when you have if you hear about carcinoid syndrome or metastatic small bowel neuroendocrine tumor, when they secrete all their hormone, they get a classic kind of flushing and diarrhea. That's what we learn. But flushing and diarrhea are hard to manifest, are hard to diagnose, because if you tell your PCP you have flushing, and you happen to be a 52-year-old woman, you'll be diagnosed with menopause for sure. If the men are diagnosed with that, then you have a problem. So, no, I have to tell you the story. Okay, I have to digress. So when I came home from Sweden for my studies, we had driven home from Washington, D.C. to New York, to Nashville. And I turned on the TV and I was really tired. And this is where I get all my medical information at 4 o'clock in the afternoon on TV. You know where I get my medical information from? Right, so Dr. Oz, right? So right after I ate all my green coffee beans, the episode is called Am I Normal? And I thought, oh my gosh, this is a loaded question, right? So what he does, tall, handsome guy, walks around the audience, and he meets this young man. He's maybe my age, maybe 35, 36. And he says, Dr. Oz, I have this weird thing. I get really flushed, and I get these hot flashes. And Dr. Oz says to him, he says, oh, it's very, very common for men to have hormonal imbalances, just like women, and blah, blah, blah. And right. So I said, I'm like a 35-year-old man. I don't remember having hot flashes. Do you remember having hot flashes? I don't. So I wrote to Dr. Oz, because I know him personally. So I wrote to Dr. Your show is great, right? I love it. I said, if you need a young Asian correspondent, give me a call. I lied and suck up. And then I said to him, I saw your episode called Am I Normal? And you interviewed a young man who was flushing. I said, I hate to, I know we've had these discussions before, but I don't think it's true that young men get hormonal imbalances like women do. You better make sure he doesn't have metastatic carcinoma. And so he writes back and says, oh, Eric, I'm glad you're doing well, blah, blah, blah. And he says, okay, I'll check. And he never wrote me back, at least about that topic. And so I will bet that young man had metastatic carcinoma. I will bet, because it is unusual to get that kind of symptom in a young man. But it's very, very common for it to linger in a young man with metastatic carcinoma. So I can make diagnoses over TV. Anyway, but there are some pearls, right? So sometimes the diarrhea is a little bit different. It's not like classic irritable bowel. Sometimes it wakes you up. It wakes you up at night because the tumor never goes to sleep, right? When you go, it's very watery and you go a lot. And ask the patient, are you afraid of leaving your house? You can see how it restricts people's quality of life. It's really quite awful. When you flush, how many times do you flush? Do you even notice it? Is it random? Is it caused by something? Does it soak your bed, right? So the ladies in here who know, it's just a soaking, you can't sleep. This is not that at all. It's dry. And wheezing as well. And so, for example, for the metastatic small bowel carcinoma with the serotonin production, these are the manifestations of skin, GI problems, and then, of course, the carcinoid heart disease, kind of the dreaded complication of it. It actually blows out the valves of your heart. And it's not the classic left-sided valves that get blown out. It's the right-sided valves. So you see how all these small little details are just a little bit different from kind of our usual classic medical school teaching. And, of course, the respiratory tract. So you can see, and there's some other ones. But flushing and diarrhea are really the two telltale symptoms. And if you have diarrhea, and you go see your PCP, I mean, well, obviously you must have irritable bowel. And so if you don't put the two of them together, it can be a very tough diagnosis to make. So now you can kind of see how reality starts to make sense when it comes to big patients' histories. And this is what happens. They'll have a primary tumor present, they'll get metastatic disease, they'll have all these vague symptoms for years, then they get systemic disease, and they start to manifest, and then finally you make the diagnosis, and then it's sometimes too late. But usually it is because we have a lot of techniques. But it's not just carcinoid syndrome. There are insulinomas that produce Whipple's triad. There's glucagenomas. There are gastrinomas that produce Zollinger-Ellison syndrome. There are VIPomas that produce the watery diarrhea, chlorhydria type of syndrome. So you can just imagine that some of these patients come through the, usually not the oncologist office, they end up there. But they will start in the GI doc. They will start with the gynecologist. They will start with the dermatologist sometimes. And then finally find their way to the oncologist. So it's a real challenge. So now, what do you do? What do you work this up? You think, wow, maybe it's possible this patient has a neuroendocrine tumor. So you basically want to test them. And luckily, we have lots of biochemical tests. So you can test for actually serotonin breakdown products. This is what 5-HIAA is. So this is the actual hormone in the urine. You can actually test directly for gastrin, insulin, glucagon, VIPoma, serotonin, and many, many others. So the hormone itself is actually a really useful marker for us. And I would argue it's actually better than even our CEAs and CA19-9s because it's a direct product of the tumor. Now, we do have other biomarkers which are more like our traditional markers, or CEAs and things. And chromogranin is kind of our workhorse for neuroendocrine because this is a machinery type of protein that comes out of the hormonal vesicles of the tumors. But there are quite a few more, and if you want to delve into this, we can certainly talk about it, but I could do 10 lectures on all these different markers, just to give you a sense. And I put this up here because I'm guessing some of the people in this room take this, if not 99% of the room take this drug, and this is a problem. Why? Despite the fact that this is our workhorse, there are a lot of problems with the marker. Sure, it's a general marker for neuroendocrine. It is not too bad. You hear me hemming and hawing because a lot of people have problems either if they have renal failure, if they have some unusual gastritis. But if you're on a PPI, it artificially elevates chromogranin. So unfortunately, I've had to chase down, because someone was referred for an elevated chromogranin to me, to the surgeon. I had to go chase it down, and it turned out to be they took Nexium. So luckily they didn't have cancer, but it was a Nexium. So it's something to consider. Now the other test we use a lot, especially for these small intestinal neuroendocrine tumors, is this 5-HIAA. This is the breakdown product of serotonin. Serotonin is just not a real stable, kind of reliable marker. If you get a bad venipuncture, that's enough to release serotonin from platelets. So that's why it's not so great. But the urine is not so bad, except if you like bananas, chocolate, and walnut. Anyone in this room like bananas, chocolates, and walnuts? Right? Everyone. And you know why? Because serotonin in your brain is the happy hormone. Right? I'm pretty sure most of you medicate yourself with this every Thursday or Friday just to get to the wheat brain. So you can see why it's a problem. So you have to avoid serotonin-rich foods, but it's actually a pretty good test. It's a nuisance because it's a 24-hour urine. Everyone knows those are really difficult tests for the patient. But you can pick up, it's pretty specific for mid-gut carcinoid, so mid-gut small intestine. And it's okay for estimating disease and survival, but this is really what correlates with cardiac valve disease. People who have elevated urine hormone have a higher risk of having valve disease, so they demand an echo. Okay, so then you can see how all these little subtleties are starting to work their way into it. But of course, your real powerful technique will be imaging, right? You want to look at the tumors themselves. And CT scan and MR, of course, are our workhorses, and ultrasound, of course, is a very useful test too in the right scenario of hands. So I want to play just a little video for you because I think this is very telling. I think this is the ideal imaging modality. You can disagree with me. Did y'all catch that? Yeah. So Superman says to Mrs. Lane, to Miss Lane, she says, you know, you shouldn't smoke, right? And she turns back all cute and casual and says, lung cancer, right? And he uses his X-ray vision and he images her. And she luckily doesn't have lung cancer. And he says, not yet, thankfully. Now, I would argue that this is a terrible imaging test, right? Because two things. One, it's in color. That's a good thing. I'll take that. The color is good. But I think the resolution, the sensitivity was pretty poor. I think we have better techniques. But it's free and it's fast and you can do it in clinic. So that's actually good. And I do wear red and blue tights in clinic. So if anyone wants to come, you're welcome. But you know, our techniques are actually pretty good. So here's a lady who had a beautiful CT scan. Unfortunately, it was because of a different problem. And the ER doc said, by the way, do you know you have a massive tumor inside your pancreas? That is not a great thing to hear from an ER doc. And you can see how beautiful the CT scans are. This is an arteriogram of the superior mesenteric artery. If you look carefully, you see this tumor right here. That's not supposed to be there. I had to dig that out of this guy as a second operation because they left it in his first operation. But the pictures are beautiful. They're really nice. But they are black and white, okay? And as much as I love CT scans, I've learned where the weaknesses are. And the weakness has to do with the timing and the protocol of the contrast. Neuroendocrine tumors are completely invisible if you don't shoot it at the exact right time. So when I do a triple, so you probably do triple phase CT scans here, right, for your hepatocellular or whatever, for your liver. I do one too, but it's a neuroendocrine program, and there's no non-contrast phase. There's an early arterial, a late arterial, and a portal phase. And if you don't do that, you will miss the tumor. I've just seen it too many times. So this is an example of where it's really good. And then inside here is where you miss it. Luckily, MRI is a very good technique, and MRI has actually been demonstrated to pick up 20% more lesions. Here's a very, very good example. It's a beautiful CT scan. This is a patient that was who lives in Birmingham. The oncologist wasn't happy with the CT scan. It was called negative because his chromogranin kept creeping up. So he ordered an MRI, and here's the tumor right here. This is the same cut, okay, from an imaging about a week apart. Here's the tumor right here, and then here's nothing here. So I took him to the OR, and I just basically lifted his liver, I scooped the thing out, and he was home in 2 days. So this is an example of how the MRI is actually a much more powerful and sensitive technique. I'll give you an example. I have a young woman who lives in Billings. Right, Billings is basically in my name. She's from Billings. She came down, she went to MD Anderson, had a CT scan. They said she had 5 tumors. I saw her CT scan, and I knew it wasn't adequate. So she came to see me. I got an MRI. She had 50 tumors. And that, you know, you can think what you want, but that, I think, would drastically change how you approach the care of the patient. So you can see having the right information is important. And I'll show you even more dramatically how it's different. Here's a good example. If you have a good radiologist, they will pick out that little funky little thing. But if I asked you to look at that, could you say that that little gray spot is different from that gray spot, or that gray spot, or that gray spot? So it's not, you can see how it would be very easy to just look through these things and miss it. But if you do the right MRI sequence, watch. It glows. It tells you where the tumor is if you know how to order the right test. So all these small details really come into play. Ultrasound is best. It's a great technique too, but it has to be in the right hands, and it really works well if it's at the end of a scope. Okay, so that's really the way it works. And you can see here, here's a well-defined 1.5 millimeter, not centimeter, millimeter tumor of the pancreas. And this tumor tortures the patient. Why? Insulinoma can be a deadly disease because if your blood glucose is 25 and you drive, that's how it's a dangerous disease. And that's all it is. That's all it takes sometimes. And if you get a CT scan in which you get, say, 5 millimeter cuts, you will miss the lesion. It will sit literally between the cuts of this image. So this is why it's such a powerful technique. So you kind of put them all together, you can see that they stack up with various strengths and weaknesses. Now, nuclear imaging is, yes ma'am?
Can you use the capsule endoscopies for the small intestine?
So the capsule endoscopy is a pretty good technique, but it's not perfect. It's labor intensive, right? So the GI doc has to sit a long time, and it can, in general, only pick up small bowel carcinoids. The problem is small bowel carcinoids, I'll show you something, are very small and deceptive, so you can miss it. The better technique is small bowel enteroscopy, where they take the scope and just shove it all the way up in the small bowel and start looking for it. That is a better way, but that is a very labor intensive technique in which you need an expert to do it. But it's the one that works the best, because not only can you find it, but you can tag it and you can biopsy it. So that's really the thing. So, but it's a good start. It's a good, relatively non-invasive way to start. So now, so I've shown you a bunch of black and white pictures, right? And I'm betting no one in this room watches black and white TV. Right? But I bet no one does. So nuclear imaging is actually the way of putting color on top of our black and white pictures. And of course, I show you black and white picture. But this is because this is a kind of a 20th century technology. This is a scan that actually is very, luckily, is very, very selective for neuroendocrine tumors. Remember I told you there's a receptor on the tumors? Well, we are actually able to put a light bulb on the hormone that binds the receptor and take pictures of it. And this is what you probably have here at Providence at St. Pat's. This is a very standard test. But you can see it's not the most detailed test. It's pretty fuzzy, right? You're certainly familiar with PET scans, right? You have a PET scanner here. So the PET scanner that you do, I don't know if you know this, is nothing but a sugar scan. That's what it is. It's just how fast does your body process sugar. Neuroendocrine tumors don't process sugar that fast because they tend to be slow-growing tumors. So this is a terrible test for that. But what we do have are very, very fancy metabolic tests, and these are PET scans as well. One looks at the serotonin production, one looks at DOPA production, and one looks at the receptor too. And you can see they pick up all these weird things. This is one that was in one of my patients' left breast. I had to excise it. So here's an artery scan. It's actually not bad, don't get me wrong. We were delighted to have it. But it's a difficult test because the patient gets injected, they hang around, they get scanned 4 hours later, they show up the next day. It's a logistic problem. And then when you get the CD, with the scans, this is what I have to work on. Right? So I get these tiny little JPEGs, and somehow they want me to operate on this. And it's not so easy. So my friend Ron Walker, he is a nuclear medicine doc, he says, X-ray scans are a little bit like looking at the sun through the clouds. You know the sun is there, but you're not exactly sure what you're looking at because you can't make things out. And so that's kind of how these tests are. And if you actually talk to any of your radiologists, I guarantee they will agree with you. It's just, well, I can imagine there being something there, and that's not a great place to be for radiology. So we were very fortunate. When I came back from Sweden, they had all this interesting technology over there. So I said, well, why don't we have it here? So I came back and I asked my friends, the old guys, and they said, oh, it's expensive, regulation, paperwork. So I called the FDA, being the naive young man I was. I called the FDA and I said, well, do we have this here in the U.S.? They said, no. And I said, why? And they said, because no one's applied. We know about this molecule. It seems to work really great, but no one in the medical community has applied for this. Why don't you go ahead and do it? I said, oh my gosh, I guess so. But I wasn't that busy, so we did. So we were the first center in the United States to be approved by the FDA to do this. And so this is essentially the next generation of that fuzzy scan I showed you. And it's a huge difference. So this is actually the very first woman in the United States to have this test. And the doc in New York said, she's had a lot of surgery. I think she has 3 lesions. I'm not sure what's going on. And so she got her test. And in fact, she had 9. And I know that because we sent her back to New York. She had her operation. They found 8. So the surgeon calls me, he says, I can only find 8, I told him there are 9, And he said, I can't find it. And I understand, it's not easy to find. I said, fine. Guess what showed up 4 months later? Number 9. Right? So we had RFA. Here's an example. This is Dennis, he's from Philadelphia. He's a 45-year-old guy, a couple children, teacher, so I love him dearly. And he had this test. And he went to a very, very prestigious center in New Orleans, a place that I would go in for patients all the time, to have surgery. He had 2 operations already. He had that X-ray scan, and they found this thing. Radiologist thought it was tumor recurrence. Surgeon said, no, that's just my operation. That's where I operated. It's my inflammatory process. So he comes to see me, and I said, look, you were just explored. I mean, you can't get any better than that. So he says, I feel great, and they can't figure it out. Can you please help me? I said, okay. So, he comes to Vanderbilt, and he got our fancy test. And this is what he actually had. And it was terrifying because, the thumbnail comes up on impacts or packs, whatever you have, comes up as a tiny thumbnail. So I had about 6 seconds to figure out what to tell this guy because he didn't have to worry about the thing in the middle anymore. It was everything else. And he is still alive. And he's cared for at a small hospital called the University of Pennsylvania. And so I still take care of him through email and telephone, but he's still alive. And this is just goes to show you, I'm pretty sure the oncologist here would agree with me, you would never find a ductal pancreatic adenocarcinoma with a scan that looks like this. So this is a very different disease with a different biology and a different treatment. Right? I want you to keep track of this. This is a gallium scan of a person who had a 5 millimeter lymph node. Right? On CT scan, it would have been enlarged lymph node of unclear significance. Right? You've all seen this before. Well, this had huge significance. I'll show you why. Okay, so let's talk about path real quick. Pathology is hugely critical in neuroendocrine, a little bit different from adeno. But you can see here we graded into 3 systems. I call it the good, and bad, and the ugly. But basically, well-differentiated tumors, these are the people who are going to live 8, 10, 15 years with their cancer. They have very low-grade tumors. And then the intermediate grade is a little more complicated, and then there's the high grade. These are just as troublesome as aggressive adenocarcinomas. And when you look at them, the well-differentiated ones are really quite beautiful. I think the pathologists like looking at them. If you look at their mitotic rate, it gives you a lot of information. But really what we start to use is a proliferative index called a Ki-67. It's a nice stain. It turns brown. It's easy for the pathologist to see. And when it's very low and quiet, that means the cells are the tumor is very quiet. It's not highly proliferative. And as you go on with the scale, you can see it gets worse and worse. And you can see the tumors get uglier and uglier. And most people have heard of small cell carcinoma, right? Small cell carcinoma of the lung. Did you know there's a small cell carcinoma of the gut? Okay. And did you know that small cell is a very highly aggressive variant of a neuroendocrine tumor? In fact, it stains with a lot of the same markers as neuroendocrine. So we kind of clump them all together. So you not only have high-grade neuroendocrine, but you have small cell inside here as well. And these are the people who are certainly going to get platinum and totiside type therapies. Okay. So don't get me wrong. You see these. But luckily, these tend to be the minority of the patients. Most of them tend to be in a well-differentiated group. And you can see survival is critical, not based just on location, but on the pathology. So if you have well-differentiated, moderately differentiated disease, these patients do relatively well if they're localized versus distant. But even distant disease, you can see the survival is worse. But we're still talking about 3 years, right? Whereas poorly differentiated, if it's metastatic, which it usually is, you're still talking about 5 months. So it's not, there's a huge difference because, and this is a problem, because if you say, well, I have neuroendocrine cancer, it is very easy to be clumped into that very slow-growing, oh, you'll be fine for 10 years, when in fact you might have a moderately or even high-grade tumor in which you need more aggressive therapy. So this spectrum is really pretty wide, and that's why it's always good to see someone who has a little more experience with it at all levels, pathology, anesthesiology, at all levels. You can see here, actually, the survival is still pretty good. I'm still pretty happy about it. But I'd like to show this graph right here, because you can see there was a huge change in the survival of metastatic disease in 1988. Anyone know what happened in 1988? Madonna was very popular in 1988. Okay. Oh, the Korean Olympics were in 1988. The octreotide came out in 1988, kind of roughly. And so this was a drug that radically changed the survival of metastatic neuroendocrine cancer. And so we're very pleased by that. So I like to show this graph because it shows the progress of the exploding. So now I've shown you how to work it up. I've shown you the pathology, the differences of the information you get from the cell itself, the tumor itself. What do you do? Okay, so I'm searching, I'm a little biased. I will say that, right? But always the first therapy is to cut it out, right? And then your second thought after you cut it out is to think about cutting more out, right? And then the third therapy you should probably give chemo. No, you should cut it out. You should think about it really, really hard. And even in the setting of metastatic disease, which I would never do for a pancreatic adenocarcinoma, you do for neuroendocrine, because removing the tumors makes a big deal. Why? So this is my friend Per Hellman from Sweden. They made us wear these cute little uniforms in Sweden and Europe. But he found that if you can resect the primary, even in the setting of metastatic disease, you can improve their survival, right? So you're talking about 7.4 years, and you just get that out. And the reason is because the tumors have a lot of mechanical problems. They bleed, they obstruct, they cause all kinds of issues for the patient, and they secrete hormones. That's really the biggest problem. So if you can debulk a lot of that tumor, you can improve the patient's quality of life and help them control their tumor burden. So it's really terrific. And because of that, it's a very different type of natural history. Neuroendocrine tumors can be very small, which I'll show you in a second, 2 centimeters, but highly, highly metastatic. Here is this is amazing. Dr. Yao from MD Anderson found the CT scan where you could find the primary and the small bowel right here. But look at the lymph node metastases and look how metastasized the liver, right? So it's like climbing up the highway to get to the rest of the nation. And the problem is most of the people don't show up until they have liver mets. Why? Because the liver metabolizes the hormone during the first pass. So if it's just in the intestine, the liver kind of masks it. But once it gets to the liver, then it has access to the systemic circulation. And the hormones give you all the symptoms. And guess when it's usually diagnosed? After they've had symptoms for 5 or 7 years. So you see how it's happening. So this is an inverted pyramid, in fact, for tumor size and metastatic spread. So I'm going to show you, I hope you all like this, I'm going to show you some gross pictures because you need to appreciate how very different it is. So here is a primary small bowel neuroendocrine tumor. It is not impressive. It is not impressive. And I will not be surprised if that tumor was 5, 10, 15 years old. But this little pipsqueak gave rise to all this liver metastases, right? And this I can't do anything about. This is miliary disease. I can't resect this. Here's some more examples, right? So this is a very classic. I'd like to think every general surgeon would recognize this. I don't think they do, but that's classic. But the problem is everything's classic. Here is another primary neuroendocrine tumor. Do you see it? You probably don't, right? I had to put a stitch around here so I wouldn't forget where it was. And here's another very classic one right here. You see it? Barely, right? And this is how it is. You have to tactilely feel for it. So when I do it laparoscopically, I get a little nervous sometimes because you can only rely on your eyes so much. So I like to just pull up a little piece of bowel so I can stick my fingers across it and my pulse. But you can see the problem. How easy would it be to pass this? I mean, I don't know if any surgeons know, but it's very easy to pass, right? And that's it. It's right there. So sometimes you miss it because it looks relatively normal mucosally on a pill endoscopy. But it gives rise to this. Look, this is a mesenteric tumor. So this is where the lymph nodes are. And this is a problem. This is not too bad. You can see his bowels are actually relatively open. But if you wait long enough, this causes a shrinking process called a desmoplastic reaction. And then these people die of chronic small bowel obstruction. You want to die of awful death, die of chronic small bowel obstruction. You can't eat, you're vomiting all the time, your stomach hurts constantly, and you don't die. It's really bad. And here's another one here. You can see it. It's awful. It can be multifocal, 1, 2, 3, 4, 5. Again, just not very impressive. And remember that little tiny one I showed you in the gallium scan with that 5 millimeter tumor? Here it is. I would have never found this. This tumor took me 30 minutes just to find because it was so small. I had to hunt through his belly to find it. But if I didn't have the map, we're listed for sure. Remember that lady with the CT scan and the ER and the big pancreas mass? Here it is. Pretty asymptomatic too. It's amazing. Classically, though, they look more like this inside the pancreas. So this is a kind of a neuroendocrine tumor right here that has a different look than the pancreas itself. Here's a patient with a lung carcinoid. You can see we resected from her lung. It's right here. Not impressive, but they cause a lot of problems. Now, the good thing is, in addition to surgery, so you've already exhausted your surgical technique, and even if you think the disease is unacceptable, please send them to a surgical oncologist or NET or neuroendocrine surgeon because they may still have the benefit of surgery despite the fact it doesn't conform to traditional adenocarcinoma rules. But even in the case when you can't treat them surgically, or at least you've already fully treated surgically, we have a lot of opportunities. And one of them is a somatostatin analog. So using the biologic function of that receptor and that hormone works really great. And it's good because we have a couple of options. We've had octreotide for 88, so we're talking about 25 years now. And this new drug called lanreotide is kind of a sister drug. It's also a somatostatin receptor. And the nice thing about them is that they're a depot version, so it's a shot you get once a month rather than having to take it as an IV form with a port or something more complicated. And you can get interferon as well. And the data on these are pretty strong. If you look at octreotide, and this was in small bowel neuroendocrine tumors, you can see patients with metastatic, unresectable small bowel carcinoid neuroendocrine cancer had a better survival if they were put on the hormone than if they were not put on the hormone as far as their progression, so the speed of the growth. And there was a really big trial called the Clarinet trial that just came out last year in the New England Journal, both looking at the same type of question. we know how powerful they are for symptom control, but this trial has actually shown us how powerful it is for tumor control as well. And you can see here, this is for gastroenteropancreatic, so digestive neuroendocrine tumors. And when they were unresectable and given the hormone, their survival was very, very good compared to those who were not given the hormone. In fact, at the close of this 2-year trial, this was a time-driven trial, at the end of 2 years, the patients on the drug actually hadn't even reached their median survival, or median progression-free survival. So it goes to show you that these relatively safe, relatively easily accessed techniques are still very powerful for treatment. Of course, traditional chemotherapy has a role. It's usually not a first-line player because these are not aggressive, fast-growing tumors. So we don't usually use it a lot. But we do have some medications here. 5-FU streptozotocin is an old drug. Temodar is really picking up a lot of steam. Afinitor, Avastin, Sutent, and of course your classic chemotherapeutics. But you can see here, we were very fortunate to have 2 back-to-back articles in the journal about 3 years, almost 4 years ago, looking at the survival of these pancreatic neuroendocrine tumors with 2 drugs, Sutent and Afinitor. And you can see this progression-free survival again. What a beautiful, beautiful separation there is. Less than 0.01 p-value. So both drugs were approved on the same day by the FDA for PNETs. So we were very delighted to have this. And I'm sure you guys are familiar with this. But these are impressive curves. Impressive curves. But you still have even more tools. You can reach into the bag and pull out since most of the metastatic disease is liver-dominated, you can treat them with liver embolization, either with radiation, chemotherapy, or even bland embolization is very effective. And I want to show you something that's a little bit more exotic. Everyone's familiar with XRT, right? So external beam radiation. Well, we have an internal beam radiation for neuroendocrine. I told you how you can use the octreotide, the key and lock system with the receptor, to treat them biologically. I've shown you we can take pictures of it. Then your next question, well, why can't you treat with it? And you can. You can put a radioactive payload behind that, have it bind to the somatostatin receptor on the tumors, and have it incorporate into the tumors and treat the patient internally continually for months. And here's an example. The Dutch really invented this. And they found that when it worked great. When it didn't work, it really didn't work at all. But these are the separation of curves as well, too. And so this is a therapy, unfortunately, not really available here in the U.S., so I still ship a lot of my patients to Europe to get the therapy done. But I've just seen too many good results. It's being tested in clinical trial as we speak, so keep your fingers crossed for those results. But here's a very dramatic example. 45-year-old man, metastatic insulinoma, rare disease, hospice, right, dying with insulin values just off the roof. They don't know what to do, so they just throw this experimental therapy at him. And this is his next scan. So he got out of hospice and was able to live a kind of a reasonable quality of life. So it tells you that there is some effect to it. Now, I told you about how to work it up. I told you about the pathology. I told you how to treat it. Right? So now let's look at what the recommendations are. So let's start with the staging system. The staging system is terrible. Right? How do I know it's terrible? Because I keep getting all these emails telling me that we're going to make the 8th edition. So I have to keep attending these meetings. I think there's one this afternoon. So make sure I don't miss that. Please make sure I don't miss that. But we're changing it for the 8th edition because it's just inadequate. If you look at the GI tumors, first of all, neuroendocrine, I told you, is a very all-encompassing type of tumor set. But in fact, for neuroendocrine, all they talk about are the digestive tract. So here's appendix, stomach, small intestine, large intestine, and appendix again. And when you stage it, it's relatively straightforward. If you have small disease, it's stage 1. If you have medium-sized primary disease, it's stage 2. If you have a large tumor or any lymph node, stage 3. And of course, if you have metastases, stage 4. Right? But obviously, most people walk in the door stage 4. So this is nothing complicated, but we're going to be changing this very soon. And we're going to incorporate other tumor types. The problem is, if you look at the pancreas, there is no staging for pancreatic neuroendocrine tumor. It just goes under the umbrella of pancreas tumor. So here's the HACC system here, which is reasonably good, but it doesn't really apply to us. So the European Neuroendocrine Tumor Society came up with their own system, which is a little bit better for pancreas. But in the next edition, we're going to actually develop a system for pancreas as well, too, which hopefully will be very similar to the ENET system. And again, you can see it's the same type of thing. Small tumors are early stage. Medium-sized tumors are a little bit later. Even some lymph nodes are okay because lymph node disease doesn't kill anybody. But as it gets more aggressive, large tumors, you can see here, and of course metastatic disease is really what we worry about. So this AJCC system is a little bit, I don't want to use the word antiquated because it's not old, but it's a little bit not useful. It's not so useful. So that's the staging, so at least you know about that. So let's talk about guidelines. Okay. So I kind of helped to edit the neuroendocrine part of the guidelines because Vanderbilt is a designated NCI cancer center. And when I looked this up, I wanted to barf. Because this is what you guys have to look for, right? The neuroendocrine guidelines from NCCN is 108 pages long. And it's torture. And I love what I do. And I can't stand looking at this, right? It's really complicated. But if you look at it kind of, if you parse it out, you can see how it's even less useful. So, you know, we create the guidelines, the team creates the guidelines, and we look at it. And it's really because we want to give you options, right? We don't want to restrict you from what it is you choose to do as a community doctor. But then it becomes a little bit of a problem because, well, here's what you should do to work it up. Okay, that's pretty reasonable. This happens to be for lung carcinoma. Okay, so you should do a BROM, you should do Altria scan, you should do all the things that you're supposed to do. And then once you figure it out, you should go do these things. And this is not too bad. Lung is actually relatively reasonable. But you can see here, still aggressive chemotherapy is what's recommended in NCCN. And even external beam radiation. Well, if you go to Europe, no one would ever do this. Right? So this is something that's a little bit in flux. So let's get to the GI tract where I work a lot more. So look at the stomach. Just look how complicated the system is. And the reason is because gastric carcinomas and gastric neuroendocrine cancers, there are multiple types. So they kind of try to parse it out between gastrocnemic patients and non-gastric patients. And you can see how complicated it becomes, right? And as a person who doesn't think about this every day, you may say, well, which pathway do I follow? Why do I do that? And look here. Here's where the small bowel becomes even more of a problem because this is certainly how you work it up. You really want to resect it. But what if you have metastatic disease? Well, if you have metastatic disease, you can do this. You can do this, or you can do this, or you can do this, or this, or this, or this, right? And it's great to have options. But if you are a new patient and you're a new doc, which one would you pick? And for someone like me who does this all the time, I know you pick this because of this, this, and this. And then you do this. And then you do this. And you do this. Right? This has very, very poor data to support it, but it's in NCCN. In fact, Novartis, which is a great company, they were so nervous about carcinoma, they didn't take this drug to the FDA for approval. So they don't even have the indication for carcinoma. Oh, it's right here. It's right here. So the devil's in the details, even when the experts are talking to you. There are guidelines, so I want to make sure you know that there are places to go. Now, you are welcome to call me. I am happy to answer your call and ask Katie. I gave her a whole bunch of my cards, so please feel free to email me and give me a call because these are unusual cases. But there are guidelines. The North American Neuroendocrine Tumor Society has nice guidelines from 2010 and updated tables from 2013, so please feel free to take a look at those. They're free. The European Neuroendocrine Tumor Society has really beautiful guidelines too, so please take a look at that. And I think they're just they give you a little more information in detail to help you make a more educated decision when it comes to taking care of neuroendocrine. Because you can see how it can be very complicated very fast, and you want to give the ideal type of therapy to the patient. And this is the problem. So here's the patient in this universe of neuroendocrine, and you have to surround them with all these people. And the problem is sometimes this patient, unfortunately, has to bounce from place to place to place. And that can be very disconcerting because then the patient starts to take control of their own care, which is always important. But it's always nice to have someone who's an expert who can really help and access the right care at the right time for that patient, so they're not trying to go to medical school for neuroendocrine at the same time. So really personalized medicine with specialty care and accessing multiple parts of the medical system can really bring them great, great benefits. So that's my last slide. Here I am up here in Kalispell. Everyone told me to step farther away from the crack. Clearly I'm not from this area. So. But just so you know, I've been working with advocacy for the past 6 months since I left Vanderbilt. And if you have any questions or want some more information, please go to our website. There's a lot of good information there and a lot of patient stories. But very, very soon I'll be hopefully relocating to Denver, so it's not too far away from you all. Joining the Rocky Mountain Cancer Center and the Presbyterian St. Luke's Hospital, which is an HC hospital, so don't hold it against them. But they're a great place, and they've been doing neuroendocrine quite a lot, and they have very good interventional oncologists, very good oncologists, And what they needed was a surgeon, so kind of that's the keystone to bring it together. So our goal is to really build hopefully a magnificent center where neuroendocrine patients can feel that they have a home, and more importantly, doctors like yourselves feel like they have a buddy where patients can go and you can call anytime and get their fancy tests and the new fancy therapies. So I thank you for your attention, and if you have any questions, I'm happy to answer them. Yeah, so pheochromocytomas are classically endocrine tumors, which usually come under the auspices of the endocrinologist. But they certainly are endocrine tumors, and they can be imaged and worked the same way. But a lot of endocrinologists feel actually relatively comfortable taking care of pheo, so I'm kind of okay with that. But when they become more complicated, or the patient wants to come, we take care of pheo as well. Adrenal, same kind of thing. Yeah, for sure. Absolutely. In the right setting. Well, apparently I explained it very well. Yes, ma'am. Yeah, that's really interesting. So her question is, if people have diabetes, could that actually be a manifestation of a neuroendocrine tumor? Diabetes is a very, very common disease, and it's mostly caused by obesity and insulin resistance. So I don't want to scare people into thinking it. But the answer is yes. And the problem is, if you're the patient who has that situation, no one figures it out usually. So there's a very classic form of a tumor called a glucagonoma, in which it causes the blood sugars to rise. And so it looks like diabetes, but it has all these other weird symptoms too. It causes people usually to become very cachectic, so they lose muscle mass and weight. And they get this weird rash that chases all over their body. And so it can be a very difficult diagnosis. So this is the one that sometimes comes to the dermatologist's office. Oh, they get diabetes, they have this rash. And then the clever dermatologist sees the two, puts them together and says, could this be a glucagonoma? And it turns out they mix that disease. So the answer is yes, but it's usually, and that's rare. It's a rare, rare situation.
The most common ones are the serotonin.
Correct, right. So the most common ones are the serotonin-secreting small bowel intestinal neuroendocrine tumors. Technically, the most common are actually the lungs. But of the digestive ones, half of the digestive ones come from the small bowel. And those are the ones that classically produce serotonin. Now, I always use the word classic because there are many, countless numbers of cases in which they don't produce any hormone at all. So the markers are no good, the hormones are no good, they're just not useful. So you have to re-scan them over and over and over again. And that's the trouble, because if you don't think about it all the time and see all these different cases, you think, oh, the tests are negative, you can't have it. But in fact, there's a relatively high false negative rate.
Is there a familial pattern or grouping for these tumors?
So in general, these tumors tend to be sporadic. But it's a little bit like the breast cancer story. 90% of the cases are sporadic, but maybe 5 to 10% are familial. And the same thing is true here. There is a familial version called multiple endocrine neoplasia, so MEN. And that comes from a mutation in a gene, which is passed on. And classically, the most common one is what we call MEN type 1. And that's from the pituitary, the parathyroid, and the pancreas. Those are tough cases because they tend to be metastatic disease, multiple tumors, multifocal, and we don't have a real clear treatment algorithm for them. But the answer is yes. But luckily, uncommon.
Are the non-secreting ones the more aggressive ones?
Not necessarily. Not necessarily. They're just the hard ones to diagnose. So you think they're more aggressive because they show up later. It's a little bit like pancreatic adenocarcinoma. If you get a small ductal adenocarcinoma that shows up right at the duct obstruction which you jaundice, you actually have a chance of being cured of the disease. But that's just so unusual. Most of the time it's painless.
How useful is bronchoscopy for diagnosing the lung cancer?
Great. It's really great. So most of the time it's picked up by incidental chest x-ray for something else. Then you CT them, and then you bronch them to get a good biopsy to figure things out. And the bronch is actually very powerful because sometimes they have recurrent bronchitis or pneumonia. In fact, it's from a collapsed lung from their carcinoid. So you can stent it or laser it, do those various things to it. So it's a very powerful effective technique. What's more powerful now is something called EBUS, endoscopic bronchial ultrasound. And you can actually ultrasound the various lymph nodes and sample them as well. So when you go to have your lung resection, the thoracic surgeon can do a very nice lymphadenectomy as well. The mistake, which is a very, very common mistake, is they won't work the patient up. They'll rush into the OR and they'll leave the disease behind. And they show up in our clinic. I have a patient who was 17 years old who had that situation, and the thoracic surgeon was a classmate of mine. I called him, I said, come on, man, you know what to do. Any more questions? Well, thank you for your attention and time. I appreciate it.